Dr. Ruchir is the director and owner of TEWARI Eye Center at Noida. He is a prominent retina surgeon with a special interest in pediatric RD and ROP cases.
Good morning, everyone, and thank you for being here. We were hoping to have a few listeners for our IC, and I think all of us are really happy to have you here. So I think my talk is going to be the saddest talk of the IC, but I'll still try to make it interesting. So when we talk about the myopic fundus, high myopia has characteristically been defined as a refractive error of 6 diopter or more with an axial length of 26.5 millimeter or more. However, these eyes do not show the characteristic pathological myopia changes. So the classic lesion of a pathological myopia is a posterior staphyloma. Unfortunately, till a very long time, till recently, we did not have a definition of a posterior staphyloma. So this was solved by Spade when in 2013 he defined a posterior staphyloma as an outpouching of the wall of the eye with a radius of curvature that is smaller than the radius of curvature of the eyeball. So now we had a definition of posterior staphyloma. With the advent of better imaging technologies such as Websource OCT and spectral domain OCT, now we have a better understanding of the myopic fundus, and a new term of myopic maculopathy has been introduced. So no discussion of myopia can start without Curtin staphyloma. Curtin was the first one who gave us a definition and a characterization of the different types of staphyloma. There are 10 types of staphyloma defined by Curtin. 5 are primary and 5 are compound. So compound are a combination of the different types of primary staphyloma. But then again, this is a fundoscopic finding. This is a clinical examination based finding. It does not take into account the layer-wise changes that are happening in myopia. This was added upon by Ono Matsui, who did an MRI-based 3D reconstruction of the eyeball to describe the different types of Curtin staphyloma, and this led to a renaming of most of the Curtin type staphyloma into wide macular, narrow macular, peripapillary, nasal, and inferior, and the other types, simply because the number of patients you see with these type of staphyloma vary according to the type of staphyloma that is there. So what is myopic maculopathy? Again, myopic maculopathy is a recent terminology. It is based on the concept that the retinal changes in myopia that happen because of the atrophy of the choroid. So basically, it's the choroid that is changing, which leads to all the visual changes in myopia. So international classification of and grading of myopic maculopathy starts from no macular lesions to a tessellated fundus, diffuse choroidal atrophy, a patchy choroidal atrophy, and a macular atrophy. Also, along with this, specific lesions such as lacquer cracks, myopic neovascularization, and fugue spots have been added into this classification. So again, if we look into the progression of myopia, we see it changing from a tessellated fundus to a stage of macular atrophy in different patients. This is a representative image which shows all the described changes. Figure A is a tessellated fundus, figure B shows a peripapillary atrophy, C is showing lacquer cracks, followed by patchy atrophy, myopic neovascularization related atrophy to patchy related diffuse atrophy. Again, newer terminologies have been introduced. Myopic traction maculopathy and dome-shaped macula. These are simply OCT-based findings, which we now come to know, which we now got to know about. So, myopic traction maculopathy is a type of macular schisis that develops at the posterior pole as a result of the axial elongation as well as the tangential forces of the ILM. And dome-shaped macula is a sort of inverse staphyloma, wherein there is an inward bulging of the sclera, leading to a thickening at the posterior pole. So what is myopic traction maculopathy? As described earlier, it is a macular schisis. So classically, it has been described on the location of the schisis, whether it is extrafoveal, foveal, whether the entire macula is involved or just a portion of the macula is involved. Recent publications also suggest towards the incorporation of the tangential traction component, and this publication by Parolini et al. Describes in a very beautiful way the evolution of macular schisis from a simple schisis to a macular hole as well as to retinal detachment. Dome-shaped macula is an interesting concept. This is I first learned about it in 2011 or 12 by seeing one of my patients. We actually published this case. This patient was being treated as a case of CSR at another place, and we realized that this was something else. And on reading the literature, I realized that the patient was actually a case of dome-shaped macula with neurosensory detachment. Now, this fluid does not respond to anything. You do PDT, you do laser, you give injections, nothing works, and it goes away with time. So I'll come to a few case-based discussions after this. So the first patient is a 16-year-old boy. Came to me with a sudden blurring of vision in his right eye. He has history of high-powered glasses in right eye compared to the left eye. BCVA was 660 in the right eye and 69 in the left eye. When I look at the fundus, two or three things are very much apparent. Right eye has a very much higher myopia grade compared to the left eye. The disc is large in size. There is larger area of peripapillary atrophy compared to the left eye, and there is a small red dot. I'm not sure whether it's visible on the image, but there's a small red dot at the fovea. On doing an OCT, I find this to be a hyperreflective mass. So this is a case of, and to confirm the diagnosis, I do an angiography which does not show any leakage at any point in time. So this is a case of a macular hemorrhage due to a lacquer crack, and the treatment is only observation. Nothing is required in this particular case. No displacement with gas, no anti-VEGF injections are going to help this child. And when this patient came back six months later, the bleed had resolved and the vision had improved to 6/12. The second patient is a 65-year-old male. So look at the contrast in the age of the patients. This is a 65-year-old male complaining of sudden onset of blurring and irregular vision in his right eye. Left eye has already been lost to macular atrophy. BCVA is 660. 6 months back, previously recorded BCVA was 6/24. When I look at the OCT, this looks like an inactive sort of a membrane complex at the fovea. However, when looked closely, there are two separate components to it. One is the lower part, which is a well-defined membrane complex, and then there is a mildly hyper-reflective area. That is actually SHREM, which signifies disease activity. And if we also look at the above area, there is a small intraretinal fluid component. So this patient has an active myopic MNV, which requires anti-VEGF treatment. This patient received one anti-VEGF injection, and this is post-op after 1 year. Now, if you compare it with the previous image, that SHREM component, the hyperreflective material component, has gone away. The membrane complex is still there, better localized as compared to before, and there is no intraretinal fluid. BCVA was maintained at 6/24. So what is myopic MNV? Again, it is a type of choroidal neovascular membrane that is seen in degenerative myopia. Now, how is it different from other type of MNVs? You do require to do an angiography in most of the cases, because this being a very inactive form of CNV may not require treatment in most cases. If there is activity described both on OCT and angiography, the first line is anti-VEGF, and unlike other type of CNVs, this does not require a loading dose. You need to give one injection and then observe the patient monthly. If any activity is noted, then again only further injections are advised. The third patient is a 32-year-old male, bilateral high myopia with cataract surgery done 3 months back. So prophylactic laser, barrage laser was done in both eyes. Patient had lots of lattices, peripheral degeneration. Right eye did develop a retinal detachment with vitreous hemorrhage after the cataract surgery, which was operated. Now, this patient came to me with a sudden onset of floaters in his left eye. This is the fundus image. This looks more or less okay, but this area shows me a vitreous membrane. So this patient has developed an acute PVD related floaters. So even in patients where laser has been done, there is no guarantee that no new lesion will form. And to my surprise, when looked closely in the superiotemporal region, just anterior to the equator, there were 3 large horseshoe tears which were posterior to the laser barrage that I had already done. So this patient underwent barrage laser again, and he was doing all right. The next patient is a 60-year-old female with a gradual blurring of vision in her left eye over the last 2 years. She's been pseudophakic for the past 10 years. BCVA was 6/60. The OCT revealed this picture. Now, this is a classic case of a myopic traction maculopathy, where you see that there is an outer retinal schisis along with an inner retinal schisis, as well as this patient is very likely to go into a macular hole formation along with a posterior pole retinal detachment, characteristic of a pathological myopia. So this patient was diagnosed as MTM. She was advised pars plana vitrectomy along with ILM peeling and gas. 6 months later, her BCVA improved to 6/24, and this is the OCT picture from that time. Then again, not all patients come to you like this. This is a 62-year-old patient, blurring of vision in her right eye for a year. She has history of anti-VEGF and gas injection 1 year back. BCVA was finger counting close to face when the patient came to me. I realized that the patient has a macular hole retinal detachment and a central atrophy. So this is the OCT picture, very difficult to capture in a patient who does not have central vision. As you can see, there is a detached retina along with a large macular hole. Again, this patient was advised pars plana vitrectomy along with eye lymph flaps and C3F8 gas. This is the fundus picture in the post-op time, and as you can see, the retina is well attached, there is no macular hole, and there is a large CNV that is seen, which signifies the previous anti-VEGF treatment that the patient received earlier. Not all patients come to you with this, and these are certain other complications of myopia with a giant retinal tear and a retinal detachment, and Colonel Pradeep, I think, will take up on that. Thank you so much.
Thank you so much, Dr. RUCHIR. That was not a sad talk at all. It was very interesting indeed.